Good evening, folks. I have discussion C for you. We're discussing chemo brain and the aging brain. There's there's two differences here. So we're going to go through both tonight for discussion C. So please join me for tonight's presentation C. Here we go. The article titled Chemo Brain and the Aging Brain. Researchers examine similarities uh, in search for improved cognition, explores the cognitive parallels between chemotherapy induced cognitive impairment, chemo brain, and age related cognitive decline. Here's the main points. Key findings: shared brain changes. Both chemo brain and aging are associated with reduced cerebral blood flow at rest and during activity, a disruption of the blood brain barrier leading to inflammation, um, accumulation of uh, sentient or uh, zombie cells that contribute to neuroinflammation. Next page. Research focus. University of Oklahoma researchers led by Dr. Anna Crisar are investigating these overlaps to identify potential shared interventions for cognitive impairment. Publications. Their findings have been published in the journals Geoscience and Aging Cell, highlighting the biological mechanisms behind these cognitive issues. Would you like to explore how these insights could inform culturally responsive interventions or caregiver toolkits? Okay, the implications of the findings on the cognitive parallels between chemo brain and aging are quite significant, both clinically and socially. Here is a breakdown. Okay, guys, now I'm going to go through both similarities for you. Okay, clinical implications. Shared therapeutic targets. Since both conditions involve reduced cerebral blood flow, blood-brain barrier disruption, and accumulation of sentient cells, treatments developed for one may benefit the other. This opens the door for dual purpose interventions. Neuroinflammation as a common pathway, targeting inflammation and sentient cells could improve cognition in both cancer survivors and older adults, potentially leading to anti-inflammatory or therapies, early detection and monitoring. Understanding these shared mechanisms may help clinicians identify cognitive cognitive decline earlier in both populations and monitor brain health more effectively. Okay, research and innovation. Cross-population studies. Researchers can now design studies that include both aging individuals and cancer survivors, accelerating discoveries and reducing society soloed approaches. Precision medicine. Insights may inform personalized cognitive rehabilitation strategies based on vascular and cellular biomarkers, social and policy implication. Caregiver support. These findings validate the cognitive struggles of both groups. Which could inform more empathetic and tailored caregiver training and support programs. Health equality. Recognizing shared vulnerabilities may help advocate for inclusive cognitive health policies that span oncology and geriatric care. Public awareness. Myth busting around chemo brain and age related cognitive decline can reduce stigmas and promote proactive brain health strategies. Would you like to co-design a framework or toolkit that integrates these findings into culturally responsive aging or survivorship programs? These findings could shape future research in several transformative ways. One, unified models of cognitive decline. Researchers may develop integrated models that explain cognitive impairment across aging and cancer treatment, rather than treating them as separate phenomenon. This could lead to broader, more inclusive clinical trials that test innovations across both populations. Biomarker-driven studies. The identification of shared biomarkers like reduced cerebral blood flow, blood-brain barrier disruption, and sensient cell accumulation can guide precision medicine approaches. Future studies might focus on tracking these biomarkers longitudinally to predict cognitive outcomes and personalized therapies. Senolytics and anti-inflammatory therapies. The role of zombie cells and neuroinflammation invites exploration of symbiotic drugs and anti-inflammatory agents as cognitive enhancers. Researchers may investigate whether these treatments can reverse or prevent chemo brain and age-related decline simultaneously. A cross-population research designs. Studies could include both older adults and cancer survivors, fostering collaboration between gerontology and oncology researchers. This approach may reduce soloed research and accelerate discovery of universal cognitive interventions. Culturally responsive and equality fostered research. Findings may prompt researchers to explore how social determinants, cultural beliefs, and caregiving contexts influence cognitive outcomes in diverse populations. Participatory research methods could be used to co-design interventions that resonate across cultures and care settings. Would you like to sketch out a research agenda or participatory study design that builds on these implications? The findings on the overlap between chemo brain and age-related cognitive decline could significantly influence treatment protocols in clinical settings. Here's how. Okay, number 1, integrate cognitive screening. Implication: clinicians may begin screening for cognitive impairment in both older adults and cancer survivors. Using shared biomarkers like cerebral blood flow and inflammation markers. Protocol shifts. Routine cognitive assessments could be embedded into oncology and geriatric care pathways. 2, dual purpose therapies. Implication: treatments targeting neuroinflammation and sensorience cells, logistics, anti-inflammatory agents could be tailored across both populations. Protocol shifts. Oncologists and geriatricians may collaborate to prescribe cognitive enhancing therapies that benefit both groups. Personalized cognitive rehabilitation. Implication: rehabilitation programs could be tailored based on vascular and cellular profiles rather than age or diagnosis alone. Protocol shifts: cognitive rehab might include neurovascular stimulation, anti-inflammatory diets, or mindfulness based interventions adapted for both age, age and aging and post chemo recovery. Cross disciplinary care teams. Implications: the shared mechanisms encourage collaboration between oncology and neurology and gerontology. Protocol shifts. Multidisciplinary teams could co-manage cognitive health and integrating insights from both fields into patient care plans. Culturally responsive interventions. Implication: recognizing shared cognitive vulnerabilities may prompt clinicians to adapt uh, participatory, culturally tailored approaches for diverse patients. Protocol shifts: clinics might co-design caregiver toolkits and support programs that reflect cultural beliefs and caregiving norms. Would you like to explore how these protocols shifts could be adapted for community-based programs or caregiver training models? These findings could profoundly enhance patient quality of life across both aging and cancer survivorship contexts. Here's how: improved cognitive function. Impact: by targeting shared mechanisms like neuroinflammation and sentience cells, patients may experience better memory, attention, and executive function. Quality of life boost. Enhanced cognition supports independence. Give me 1 second, guys. Okay. Next page. Be right with you. Decision making and emotional well-being. Tailored rehabilitation programs. Impact: cognitive rehab could be personalized based on vascular and cellular profiles, not just age or diagnosis. Quality of life boost. Patients engage in therapies that feel relevant and effective, like mindfulness and anti inflammatory diets, or neurovascular stimulation. Okay, collaborative holistic care. Impact. Multidisciplinary teams, oncology, neurology, and gerontology can co-manage cognitive health. That would be nice if they could both, if they could all three come up with some care team for those who have that issue. That would help them preserve some life, have some benefit out of the research. Okay, so next sheet. Quality of life boost. Patients benefit from coordinated care that addresses the full spectrum of their needs: medical, psychological, and social. Culturally responsive support. Impact. Clinicians may co-design caregiver toolkit and interventions that reflect cultural beliefs and caregiving norms. Quality of life boost. Patients and families feel seen, respected, and supported in ways that align with their values and lived experiences. Okay, reduced stigma and greater empowerment. All right. Next one. Impact. Validating chemo brain and age related cognitive decline as biologically linked can reduce stigma. Quality of life boost. Patients are more likely to seek help, engage in treatments, and advocate for their cognitive health. Okay. Would you like to co-create a patient-centered framework or toolkit that translates these insights into actionable strategies for caregiver and clinicians? Okay, these findings could influence healthcare policies in several strategic and equity-driven ways. Okay. Expanded cognitive health coverage. Guys, I'm going to try and get this all done for you tonight. Okay. Policy impact. Recognition of shared biological mechanisms between chemo brain and aging may prompt insurers and public health systems to cover cognitive assessments and interventions for both groups. Example, Medicare, Medicaid could broaden eligibility for cognitive rehab services beyond age-based criteria to include cancer survivors. Integrated care models. Impact. Policymakers may support cross-disciplinary care teams that include oncology, neurology, and gerontology to manage cognitive health holistically. Okay. Almost done, guys. Example, funding incentives for clinics that adopt integrated cognitive care protocols. across specialties, culturally responsive programming, policy impact. Findings could justify and investments in culturally tailored caregiving toolkits and community-based cognitive support programs. Example: grants for participatory design and initiatives that reflect diverse caregiving norms and beliefs. Okay, research funding priorities, policy impact. Agencies like NIH or NIA may prioritize studies that explore shared, hold on, cognitive decline mechanisms across aging and cancer treatment. Example: cell calls for protocols, proposals that bridge geoscience and oncology, especially those using biomarker driven or equality focused designs. Public health campaigns, policy impact. Governments may launch awareness campaigns to destigmatize chemo, brain, and age-related cognitive decline by highlighting their biological basis. Example: educational materials that empower patients to seek help and advocate for cognitive health, guys. Okay, one more sheet. Okay, would you like to co-develop a policy brief or advocacy strategy that translates these insights into actionable recommendations for health systems or legislators? Okay, guys, did that one for everybody's FYI. Hope that helps somebody understand chemo, brain, and age-related cognition. So, with that being said, I will see everybody Monday for shows. For now, Gator Wellness, take care, folks.